So today we are talking about how volunteers can recognize and report incidents of suicidal ideation in hospice patients. Now, first, I want everyone to understand that it is not at all unusual for hospice patients to think about death and even about ending their own lives. As caring professionals, which is what all of you are, it's our responsibility to address our patients' concerns and to provide them support. Of course, that's what volunteers do. In short, we provide presence and support. And so our updated policy at Hosparus Health outlines how all members of the interdisciplinary team, including volunteers, because as patient and family support volunteers, you are considered a part of the team. So how everyone is required to help. And we're going to identify a couple of things. First of all, our objectives are to identify 3 to 4 suicide risk factors for patients in palliative and hospice care, identify common myths about suicide, discuss what role volunteers play in supporting at-risk patients, and learn how to report suspected incidents of suicidal ideation. Now, many of our patients may have thoughts of harming themselves or thinking specifically about how they may end their life. It is not at all unusual for hospice patients to think about death, certainly, and about ending their own life. And so we're going to talk about suicidal ideations. So these are thoughts or ideas about ending one's life, and it's a broad term that's used to describe a range of contemplations, wishes, and preoccupations with death and suicide. It's important to note that volunteers are not responsible for diagnosing, screening for, or documenting suicide risk in hospice health patients. That is not your job, thankfully. That is the job of the clinical team. Your job is, again, to provide presence and support. And if you notice or if you become worried that someone is really thinking about ending their own life, we need to know about that. So let's talk about depression and how it differs from having thoughts of suicide. Depression is a common mental disorder. My guess is all of us have felt depressed at some times, and some of us may also have ongoing depression that perhaps is being treated by a mental health professional. Depression is characterized by persistent sadness and a lack of interest or pleasure in what used to be rewarding or enjoyable activities. And depression, of course, can also disturb sleep. It can affect one's appetite, and it often causes tiredness and poor concentration. Now, let's take a look then at how depression is different from suicidal ideations. So as we talked about, suicidal ideations are often called suicidal thoughts or ideas, thinking about ending one's life. It's a broad term used to describe a range of contemplations, wishes, and preoccupations with death and suicide. Suicidal ideations present in a waxing and waning manner. So those thoughts kind of come and go. And the magnitude and characteristics of suicidal ideations fluctuate dramatically. Suicidal ideations can vary in intensity, duration, and character, and there is no typical way that suicidal ideations present in a specific person. Most people have control over suicidal ideations, and they do not attempt suicide. So that's important to remember. Again, our patients often think about that, but they are not going to carry out that act. They're not going to act upon it. So let's look at some symptoms you may see in your patients that are associated with depression and/or suicidal ideations, and a bit about what our clinical staff are required to do. So our clinical staff, i.e. our nurses, our social workers, and our chaplains, are always thoroughly assessing and monitoring the pattern, intensity, nature, and impact of suicidal ideations on a patient, and then documenting this in our electronic medical records in Suncoast. It's also important to reassess suicidal ideations, as we just talked about. They come and go. And so the staff are on an ongoing basis trying to identify whether or not that person is at risk for ending their own life. It's interesting to note that after declining in 2019 and 2020, suicide deaths in the United States have increased approximately 8.6%. So that's quite a bit. And I bet all of us can come up with reasons that this has happened. But if it is more prevalent in the general population, we can assume it is more prevalent in our hospice patients. Estimates are that 24 to 70% prevalence of depression in hospice patients. So that's quite a bit, 70%. Depression in this population often leads to a decrease. Depression in this population leads to a decreased quality of life, and it could lead to a desire for an earlier death. Here are some of the risk factors for suicide in hospice patients: depression, pain, debility, hopelessness, a sense of being a burden to others. And it's important to know that suicide is more frequent within the first months after diagnosis and then soon after discharge from the hospital. As death approaches, there is an increase in the prevalence of severe depressive symptoms. So research indicates that patients with depression should receive interventions to manage their symptoms. And those interventions can include social support. So depressive incidents, so being depressed, is a risk that's higher in patients with higher symptom distress. So that makes sense. If you have increased symptoms, if you're in pain, if you are losing the ability to get out of bed, to care for yourself, if you have dependence on others, and if you perceive yourself as being a burden on others, that's going to increase your depression. But it's lower. Depression is lower in patients who have higher levels of affectionate support and positive social interactions in their social networks. Now, that's a really important one to sink in, because that's why you're here. That is part of your role as a volunteer, is to provide that support, to be someone who provides social interaction and who cares for your patients and for your families as well. That's a big deal. And that's part of the reasons why I just think you guys are the best. You do such important work. Now, here's an interesting thing to note. Cancer patients have nearly twice the incidence of suicide relative to the general population. So I'd like to you to think for a minute about why that might be. And we'll talk more about that in a minute. But it's important to note that the general suicide rate of cancer patients declined from 2000 to 2018, which is correlated with an increasing utilization of hospice and palliative services over the same time period. So isn't that interesting? Another one of those stats that just indicates that when people come on our service, they do better. Depression in terminally ill patients is both underdiagnosed It's often dismissed as normal and an anticipated response to illness. And oftentimes it's not considered at all. And so depression could be misdiagnosed. It could be mistaken for delirium or poorly controlled pain. And because of the clinical complexity of some terminal patients, it becomes even more complicated. So, for example, patients with cancer who have endured chemotherapy and radiation treatments are more likely than not to experience sleep disturbance, fatigue, anorexia, so they lose their appetite, and weight loss, whether they're depressed or not. So again, you can see how this can be confusing sometimes. Diagnosing and treating depression in terminally ill patients has some real challenges. Some studies indicate that clinicians should have a low threshold for treating depression in terminally ill patients. In other words, they should just kind of assume that everybody is at risk, and so we need to look at it very carefully in every single patient. So some physical symptoms that we see in all patients is that, again, that change in appetite and weight, the sleep disturbance, fatigue, loss of energy, the diminished ability to think or concentrate. And some of the emotional symptoms we see are tearfulness, a depressed appearance, social withdrawal, decreased talkativeness, brooding, self-pity, and pessimism. So let's take a look at some symptoms of depression that can also be signs of suicidal ideations. And so I'm going to share some terms with you that you may have heard of or maybe not. Anhedonia. Anhedonia. That's a term that's fairly new to me, but in short, it is the inability to gain pleasure from normally pleasurable experiences. Let me say that again. Anhedonia is the inability to gain pleasure from normally pleasurably experiences. So even patients in our care who are non-depressed, they can refocus their interest on those activities that are less physically or mentally demanding, and they don't necessarily lose interest in activities altogether. They are still finding meaning in their daily life. They're finding things that they can do that bring them pleasure. In our patients, though, who are suffering from depression, that is not the case. Hopelessness. Hopelessness is another hallmark. Hopelessness is the strongest predictor of suicidal ideation and that desire for a hastened death. Hopelessness seems to be able to directly influence the physical health of medically ill patients. And worthlessness. I'm afraid we see this fairly often, and it makes me really sad. And that's when patients feel like they have nothing left to contribute, that they don't have any substantial contributions left in their life. They're done. They're worthless. They are a burden on others. And so sometimes they feel guilt. Our patients can feel responsible for causing the terminal illness. So let's say it's someone who smoked for years and years, and now they have lung cancer. They will have that added guilt along with the burden of their care. Patients often emphasize their past mistakes, and they seem now overwhelming or pervasive now that they are at the end of their life. And sometimes they feel like they're a burden to others, or they believe that they, again, have caused their own illness for some reason. So I want to talk to you about a real life case study in Hosparus Health. And we're going to call this patient Bruce. All the names have been changed. Of course, HIPAA is important. So Bruce is a 71-year-old white male who was admitted into hospice care 2 months after a diagnosis of progressed kidney cancer. He has a history of alcohol abuse and has been sober for 5 years. Bruce has been married for 40 years. He lives at home with his wife and dog. He has 2 children, a daughter that he just reconciled with in the past few years, and a son who died 2 months ago from alcohol addiction. He also has a brother who died from alcohol addiction, or from addiction. We don't really know what kind, and a son-in-law who completed suicide. So a lot of tragedy in Bruce's life. He identifies his support system as his wife, and she has not acknowledged to him that he is in hospice care yet. His daughter and friends are other supports, and he has been highly involved in AA and was attending meetings daily until he became too tired, and now he attends weekly. So here's Bruce. He's been admitted into our care. What happens next? Well, all of our clinical staff use a screening tool to identify and track emotional symptoms. And over time, they're able to capture the changes that they see in their emotional well-being. The clinical staff use a validated questionnaire to monitor all these symptoms, and they ask the patient questions. So this tool is also dependent on patient participation. That makes it a little bit more tricky. Some patients are a little bit more reticent and they don't necessarily want to talk about it. But this questionnaire can be used at every single visit. Remember, we're tracking that ebb and flow. So let's go back to our patient, Bruce. When the social worker visited, remember, our social workers are the folks who address and care for the psychosocial piece. So they're highly, highly involved in this area. And on the visit, the social worker identified that Bruce did have some coping skills. These are important. His coping skills were smoking, his dog, his grandchildren, the AA support group, his AA sponsor, and working around the house. Now, I want to emphasize here that many of our volunteers, understandably, choose not to go into homes where they're smoking. That makes sense. And it's easy for us, I think, to be judgmental about our patients who smoke. They're dying. They're sick? Why are they smoking? Or smoking caused their illness. Why are they keeping on doing it? Well, for one thing, they're at the end of their life, and really they can do just about anything they want to, because in some ways it doesn't matter at this point. But the other piece of it that we're reminded of here is that smoking can be a coping skill for people. And so it's important. The patient reports he has no pain. And so the social worker did make a bereavement referral because the patient is struggling with grief around his diagnosis and disease progression, but also around the losses that he has had. Most recently, his son, who died 2 months prior due to alcohol addiction. So now you're seeing not just that immediate interdisciplinary team, the nurse, the social worker, the chaplain, the CNA, the volunteer, but now also the bereavement team coming in to support this patient. A bereavement risk assessment was completed on the patient, and he is in a high risk level. So then the nurse or the rest of the team, let's look at what the rest of the team does. So the team nurse completes that ESAS. That's the name, the acronym for the survey that they use, that clinical assessment tool. So she completes that at every single visit, again, to track that ebb and flow. His symptom scores begin to increase over the 2 months, and along with his disease progression. And so she or he, the team nurse, is noting an increased depression and increased pain. So that puts him at a higher risk. The grief counselor is seeing the patient weekly for support around his grief. So that's a good thing. Along with the social worker, that grief counselor is tending to Bruce from a psychosocial perspective. And then, although the chaplain services were declined after the initial visit, the social worker is completing bi-weekly visits. So on the focused visits, when the team members go in, they see that Bruce is now reporting increased pain and increased depression. He tells the nurse he's feeling more irritable and is reporting some fleeting thoughts about suicide. He can no longer go to his AA meetings, and he can't leave the house as he was able to do before. He continues to express fear about what is coming. Bruce was able to enjoy crosswords and playing with his dog, but now he's finding that he is thinking a lot more about ways to numb any feelings. So, Bruce is feeling pretty bad right now, understandably. Because this has reached a level where there is heightened concern, the interdisciplinary team, calls a care conference. And this happens not infrequently with patients and families who have high needs. So the intent is, on top of the bi-weekly meetings that our interdisciplinary team members have, where they talk about every single patient, this care conference is held with the entire team for a longer period of time. So they really have that ability to go in depth into what each person on the team is seeing. So the team explores bringing the chaplain back in to offer support around the patient's existential distress. The nurse continues to assess and will continue to assess for further pain management. So if his pain is getting out of control, how do they address that with medication? The grief counselor says that they will increase visits if needed, as will the social worker, increase visits for additional support. And then the doctor on the team is going to actually go and meet with the patient to explore medication needs. So what can they do to help make him feel more comfortable and more at ease, both physically and psychologically? The suicide risk assessment is completed, and the patient reports that his daily thoughts about wanting to kill himself due to family conflict and is decreased, and decreased functioning. I'm sorry. Let me say this again. The suicide risk assessment has been completed, and the patient reports daily thoughts about wanting to kill himself due to family conflict and decreasing functioning. So his risk is escalating, but he currently has no means to complete suicide. So what does that mean exactly? Well, if a patient is bedbound, if they cannot get up out of bed, if their meds are given by a family member and stored elsewhere where the patient can't get to them, if there are no guns in the home, or if there are, that they are kept locked up and Bruce, again, is bedbound and can't get to them, then we know that that risk is reduced a bit because there's no way they can do it. And the social worker has now assessed that the patient is at a moderate risk of suicide. So what's the volunteer role in all of this? We're talking about the interdisciplinary team, and you are a part of the interdisciplinary team. Well, it's simple in some ways. It is to be aware of the suicide myths and facts that we're going to talk about here in just a minute. It's also to understand what those risk factors are, and then to listen for verbal cues. So let's take a look at that. One myth is that confronting a person about suicide will only make them angry and increase the risk of suicide. And that, of course, is a myth. It's not true. What we know is that asking someone directly about suicidal intents lowers their anxiety. When they can open up and talk about it, when they have open communication, it actually lowers the risk of an impulsive act. And research supports this fact. Suicidal people need to communicate their distress. This is the beginning to reducing it. So suffering alone adds to hopelessness and despair. Another myth is that suicidal people keep their plans to themselves. It's true. We do know and hear of people who suicide seems completely out of the blue. And yet, most suicidal people communicate their intent sometime during the week preceding their attempt. Again, research supports this fact. Suicidal people need to communicate their distress. So it's important that when we spend time with patients, that we allow them to present their authentic, imperfect selves to the world, to you. Because a patient's sense of belonging can never be greater than when they have some self-acceptance. And you as a volunteer are a huge part of this. It's part of the reason when someone is talking about how badly they feel, how they're depressed, how their life has changed, that one of the things we do not want to do is to try and cheer them up. Instead, our job as a volunteer is to listen without judgment. Another myth is that once a person decides to complete suicide, there's nothing anyone can do to stop them. The fact is, suicide is the most preventable kind of death, and almost any positive action has the ability to save a life. It could save a life. So here are some risk factors to consider. We've talked about poorly controlled pain, mild delirium with poor impulse control, if there are guns in the home. Interestingly, white people commit suicide more frequently than people of color. Males are at a higher risk. Veterans are at a higher risk. People who are 60 or older, who are single, who have a history of suicide attempts, who have experienced multiple losses, and or who have a history of psychiatric illness or substance abuse. So these are all risk factors to think about. So let's go back to our cancer patients, those who show an increased risk for suicide. Research indicates that 60 to 90% of advanced cancer patients report moderate to severe pain. So again, poorly controlled physical pain. That's part of the reason they're at an increased risk. Men that have a gun in the home are 8 times more likely to die, to complete suicide, versus those who don't have a gun in the home. And women are 35 times more likely to commit suicide if they have a gun in the home. Now that's really interesting, isn't it? David, well, that's the person who did this research. His name is David Studert. He also found that there is a higher percentage of veterans who died by suicide, especially when they were diagnosed with chronic pulmonary disease. And then, of course, that mental health and substance abuse use, those are things that increase that risk, particularly among veterans. So what are some of the verbal cues that we might look for? Some of the things that you might hear are, I've decided to kill myself. I wish I were dead. I'm going to commit suicide. I'm going to end it all. If such and such doesn't happen, I'll kill myself. Now, these are direct verbal cues. They are different from some of the indirect verbal cues that we hear sometimes, like, I wish I would just go to sleep and not wake up in the morning. There's no indication that they're really thinking about taking their own life. but they're tired. They're ready to go home. You hear that a lot. I'm just ready to go home. I don't understand why God doesn't take me. So some of the factors that can decrease the risk of suicide are the ability to cope with stress, religious beliefs, a fear of death or the actual act of killing themselves, cultural, spiritual, and or moral attitudes against suicide, pets. Beloved pets are a huge help. Supportive family and friends, positive relationships, and identifying reasons for living. So some of those indirect verbal cues we just mentioned are I'm tired of my life. I just can't go on. My family would be better off without me. No one will care if I'm dead anyway. I just want out. I won't be around much longer. Pretty soon you won't have to worry about me. Now, we might hear these kinds of indirect verbal cues in patients who are not thinking about ending their own life, but it could also mean something more. So that's the complexity here, those shades of gray. So if you're sitting with a patient and you hear some of these things, you want to be supportive, and it's important to ask about it. But how you ask about it is really less important than that you ask it. So if in doubt, don't wait, just ask the question. If the person is reluctant, be persistent. Talk to the person alone in a private setting if you can, and allow the person to talk freely. Again, all those great skills that each of you learned when you came through new volunteer orientation, how to listen with compassion and actively, and then give yourself plenty of time. So here's a direct approach to asking. You know, when people are in a pain crisis, as you seem to be, they sometimes wish they were dead. I'm wondering if you might be feeling that way too. Your statement seemed downcast and without hope. I wonder if you're thinking about suicide. Are you thinking about killing yourself? Now, do you hear the tone in my voice? So all of these are non-judgmental. They're showing your concern. And then finally, have you talked to your team members about these thoughts and feelings? So important, because another role of patient and family support volunteers is to always connect that patient back to other people in the interdisciplinary team whose job it is to take care of whatever they are worried about or complaining about or experiencing. So here's some ways not to ask the suicide question. You're not thinking of killing yourself, are you? You wouldn't do anything to let your family down, would you? Suicide is a dumb idea. Surely you're not thinking about suicide. Remember that empathy has no script. There's no right way or wrong way to do this. It's simply listening, holding space, withholding judgment. So all those questions that I just asked, they were all very judgmental. And I have to tell you, you know, a lot of us have that fire in us, that desire, that habit of just speaking plainly, just telling people exactly what is on our mind. That's not our role as patient and family support volunteers. Our role is to withhold our own thoughts, our own judgments, our own beliefs, and to connect emotionally, because as Brene Brown says, it is that incredibly healing message of you're not alone that is so powerful. So what do you do? What do you do if you suspect your patient is depressed and is at risk for suicide, but you can see there is no immediate danger? All those things that I talked about, the patient has no way to complete suicide. The first thing to do is to call your manager to share your concerns. And this is one of those times where it's important enough, if you can't get a hold of your volunteer manager, to just go ahead and call customer support. and let them know what's going on. Now, chances are customer support rep is going to pull up the patient's records. They're going to see, oh yeah, the team is watching this. It's all there. You also will want to report if you believe your patient is likely to complete suicide. And then you call customer support directly. They will immediately contact the nurse or the manager on call, and they will send somebody out. So, and let me just go back for a minute. Customer support, the number is on the back of everybody's badge. And when you call, just press 1. Press 1 is going to get you directly to a customer support rep. You should have the patient's name and their ID number there so that the customer support rep can look it up very, very quickly. But call customer support, press 1. So let's see how Bruce wound up. So Bruce and his wife agreed that the chaplain could start visits. The chaplain supported both Bruce and his wife and helped them with their spiritual distress that they were experiencing, and that really did offer some peace. So again, remember, they had at first declined the chaplain, but later they let the chaplain come. And that's not unusual too. People think, oh no, I don't need a chaplain. But as their disease progresses and they feel some of that existential distress, they'll ask for a chaplain. The social worker utilized life review, which offered comfort and peace to the patient and his wife as well. So as he was able to think about and verbalize all the great things that happened in his life, he felt that sense of peace. The team doctor, provided an antidepressant to decrease the symptoms of depression. The nurse effectively managed his pain, which also decreased thoughts of suicide. The grief counselor met with Bruce several times prior to his passing to support him and his grief. And I will also say that for a patient who has a volunteer, that volunteer visiting and being a part of their care would have been a huge and very important piece of the story. So let me stop our recording